It's so good to see some new faces, some old friends. Srinivas, Sushil, thank you for inviting me. So my topic today, before we get the live case, is breaking the myths, talking about TAVI hemodynamics. And the way I'll do it is similar to what I've done in the past, which is just go with what the myths are, and I'll tell you why I think that they are a myth. Okay, so myth number one, there is no role for invasive hemodynamics during TAVI. Obviously, with those of us who were in the live case just a little while ago, we know that that's not true. But can echo really tell me all that I need to know? So here's a case, 87-year-old with symptomatic aortic stenosis, suitable for TF tower with a self-expanding valve, 29 evolute, underwent successful procedure similar to what we do all the time, conscious sedation, transthoracic echo, discharged home with just mild AI. We thought that would improve. But over the next several weeks, noted increasing shortness of breath. And it's very unusual for patients to actually feel worse after a procedure like this. So it always prompts us, is this something that we're missing? We got an echo, it continued to show mild paravalvular AI. This is his procedure, and once we released the valve, it actually settled down nicely, and you can see an echo on the back. So we brought him to the cath lab for an invasive assessment. And here's what his gradients look like. So not surprisingly with self-expanding valves, in fact, with all newer generation tower valves, that there's not much of a gradient. But notice that the diastolic pressure is low, the LVEDP is high, and you can see the trend between aortic diastolic and LVEDP. And sure enough, once we repeated the aortogram, you can see that the valve is a little south. So severe AI demonstrated nicely with hemodynamics, and as is pretty evident, low position of self-expanding valve, probably post-deployment migration, and this one was treated with a self-expanding valve within the prosthesis and had a really nice result. Now, when we look at comparison of hemodynamics with echocardiographic measurement. Initially, when we started doing this, and I think some of you might not know, but Sushil was actually my very first proctor when we did this valves about 12, 15 years ago. And we thought that these two modalities are fairly similar. But now there's an increasing recognition that there's a discrepancy between echo and catheter-derived gradients. It's quite well known. We also know that there's an overestimation of transvalvular gradients from Doppler-derived measurements versus invasive measurements. And there are different hypotheses on why that might be the case. There's a pressure recovery phenomena. There's the Bernoulli equation limitations that we use to calculate echo gradients. There's also a downstream increase in pressure due to conversion of kinetic energy to potential energy, resulting in overestimation of Doppler gradients. Now, this is a phenomena that is probably similar in all transcatheter valves and maybe more pronounced in some versus the other. There's also contributions from the valve morphology. For example, if you have a tunnel-like AS, if you have hypertrophic cardiomyopathy, a subvalvular or supravalvular stenosis, the aortic valvular size. These are all issues that we're continuing to challenge on what the option is. For example, OpSense is a new wire that could get really high fidelity gradients just during and post-tower. But where they fit in this whole scheme of things, it remains to be decided. So myth number one, echo cannot tell us all that we need to know about hemodynamics. Rather, we would use a complementary technique similar to some of the live cases we saw where a TEE in one case showed us that that was the correct thing to do, and invasive hemodynamics in the valve-in-valve case showed us that that was the correct thing to do. Okay, talking about valve-in-valves. So myth number two, valve-in-valve is a simple procedure. In fact, our surgeons like to say, oh, this is so simple rather than a redo tower, and that we could use on-table hemodynamics to optimize valve performance. And this may be a little controversial, and if we have time left over, I'd be curious to see what our panel thinks. So here's a case, degenerated surgical bioprosthesis, the type of case that we do pretty much every week, and got a self-expanding valve. You can see a slice constraint on the right side panel. We ballooned it, but not really fracked it, got a gradient of 11, and this was a bit earlier on in our experience. And we said, okay, less than 20, which is what traditionally people have used for structural valve deterioration, and we'll come to that here in a second, and let it be. And then a year later, that 11 went to 35. And this is the sort of patient that comes in at day 30. The echo gradients look a little worse. Then you start them on anticoagulation, and you watch the gradient, et cetera. But long story short, her shortness of breath continues to increase, and so she was referred for a redo surgical aortic valve, which is challenging. She wasn't a great candidate to begin with, and once these valves, especially the taller valve like the self-expanding prosthesis, get incorporated in, they're a bit challenging to deal with. So talking about valve-in-valves, hemodynamics, durability, the short-term results of valve-in-valve are generally quite good. Obviously, if you watch the pitfalls, if you take a good look at the CT, most of these cases do really, really well. However, what is pretty clear, and I think we touched on that conversation during our live session, is that gradients are important, hemodynamics are important, and I think we didn't really get to what that does to durability. So clearly, 1-year mortality after valve-in-valve TAVR is high with smaller surgical valves, to nobody's surprise in this room. And then compared to the larger valves, which are greater than 27, and if you take 23 or 25 as the intermediate standards, patient prosthesis mismatch is one likely scenario, although probably not the only one. And then some of the strategies which we touched on to improve these hemodynamic results and reduce risk for a patient prosthesis mismatch is implanting the transcatheter valve high just to optimize the leaflet function, using a supraannular THV, especially in the smaller surgical valves, and then bioprosthetic valve fracture with a high-pressure balloon inflation using a non-compliant balloon to either remodel or entirely fracture the surgical valve ring. It leads to a more optimal expansion of the transcatheter heart valve, and then it mitigates the risk of patient prosthesis mismatch. Now, we won't get into the debate of whether to frac it or fracture it before or after, but now it has become fairly standard in our practice. So here's a transcatheter valve, and you can see it's a valve-in-valve prosthesis. And then on the right, you can see nice expansion of the valve frame after a non-compliant balloon. And these patients, at least in our practice, go home with very little gradient and have good outcomes. So in general, I don't even bother that much about hemodynamics, honestly, and I'd be curious to see what the panel thinks. We basically, if a valve is fracturable, we just fracture it. And some of these valves I've listed. I won't I won't call out all of them. Magna East, Perimount, MitraFlow. You can fracture. Some can be stretched or remodeled, but not fractured. So CE, as we saw earlier, Trifecta, Inspiris, Perimount, and then some you cannot fracture or remodel, which is Hancock and Avalis. Especially true if the surgical prosthesis is less than 21 millimeters. All right, myth number 3, which is an interesting one. So myth number 3 is that valve misalignment or commissural alignment, and we talked about that with the MyValve case, and we talked about that with the original case by Ravinder, that it makes subsequent coronary access hard, but has no impact on hemodynamic performance. And I'll show you some data that actually suggests that is not true. What we do know is that patients with elevated gradients, more than 20 is what the TVT registry, which we follow in the US, shows to be an indicator of structural valve deterioration. And the patients with high gradient, the hospitalization rate is high, no question. The residual gradients, again, affect late mortality. So I think this issue is clearly important. And when we look at the valve hemodynamics, and we also in our practice have a very low threshold, for repeating a CT after transcatheter valve, just to understand how these valves are aligned. And this was a paper from last week that shows, and I want you to focus on the last part of this, that when when it's a misaligned, and this particular study was in balloon expandable valve, then the relative AV gradient increase is far higher in that group. In fact, the odds ratio of 2.35. So 17 or 18% of those cases had a relative AV increase. So this is something that we are continuing to understand, continuing to study, but suffice it to say that commissural alignment has more impact than just coronary access. All right, so now as just a little bit about the alignment piece, in contrast to surgical valves, TAVR does not yet have the ability to align the prosthesis. I don't have experience with my valves. I'm curious to see what people do on the alignment piece of this, on how you approach it. We know that with certain good standard techniques with pre-procedure planning and CT, and for example, on the self-expanding valve, the tabs, you can get to about anywhere from 75 to 90%. However, the hemodynamic and clinical outcome is much different, is what this data would suggest, and we would need to understand more on how you could use rotational orientation to provide better hemodynamics, not just coronary access. Certainly some of the newer generation valves that we've seen in prototype have the ability to rotate the valve in the annulus to align it that way. So that'd be an interesting advance. Okay, myth number 4, echocardiography can reliably demonstrate structural valve deterioration. Certainly the standard of care is that we use echo at 30-day time frame, at 1-year time frame, or if their clinical condition changes, to see how the valve is performing. And this is historically defined as at least a 10 millimeter gradient increase in mean gradient, or just in isolation, a mean gradient of at least 20 millimeters of mercury. And this is what we use to guide our decision making, to say where or which valves have deteriorated, and then that leads to a pathway of which patients we should anticoagulate, et cetera. Now, the evidence for discordance between echo and direct invasive measurement, all of us have seen that. When we've seen these hemodynamics, your invasive hemodynamics just after valve implantation looks close to 0, yet you get an echo gradient that is about 5 or 6. So this was actually an interesting study where they looked at, it's a small 13-case series from Vancouver, where they took patients who had structural valve deterioration by echo and then took them to an invasive gradient. And what they found was that a significant number of them invasively did not have structural valve deterioration. So this has significant implications on how we treat this, how we approach this, and I think we will know more about this field as time goes. So I think I'll stop here.